Hello, you are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, today I talk to you about the application of the median nerve, yes, as far as the clinical setting is concerned. My friends, the good news about the application of the median nerve is that, yes, by way of root value, something we know about it, just like what we discussed as far as the radial nerve, yes, is concerned, we said that by way of root value, the contribution will be coming from the entire, origin of the brachial plexus. And so it tells me that the root value of the median nerve is, of course, C5 all the way to T1. Now, the good news, the one I was trying to tell you about is that when we looked at that of the radial nerve, yes, it gives some supply in the axilla, in the armpit, it gives some supply of course in the arm. But my friends, in the case of the median nerve, you don't need to bother about these areas. Okay, why? Because the median nerve will not give neither motor supply nor cutaneous sensation to any of these areas. And so whenever there's an injury to this median nerve, yes, in a higher area like the armpit or in the arm, okay, in whatever area I'm going to discuss to you, the clinical presentation will remain the same. Okay, so that's one useful thing I want you to become aware of. And so importantly, discussing the median nerve to you so that we can look at the clinical application, where I want you to begin from is that we look at the lower aspects, okay, as far as transiting from the anterior aspect of the arm to the forearm. There's an area over here, which of course we call the elbow. And so the fossa over here is what we are calling the cubital fossa. And we know something I've discussed already in some of my previous videos that, of course, when you look at the cubital fossa, we have some contents. And as far as the content of the cubital fossa is concerned, the medialmost content is, of course, the median nerve. Okay, so medialmost content of the cubital fossa is, of course, the median nerve. Okay, because we know that transiting from, of course, the lower aspect of what we call the arm to the upper aspect of the forearm, yes, that area is the elbow, and that's the cubital fossa anteriorly. Okay, so I want you to understand that. That's the first thing. Now, once it emerges from this area, then first thing that I want you to understand is that this muscle will pierce a muscle, okay, or will run between the two hairs of a muscle. And my friend, this muscle that we are talking about is, of course, pronator teres muscle. Pronator teres muscle. So it tells me that as far as motor supply of the median nerve is concerned, the first muscle is going to give motor supply is, of course, the pronator teres muscle. Okay, yes, by running through the two hairs, okay, the ulnar and of course the radial, the humeral hairs, then what will happen is that yes, it's going to give motor supply to these fibers. That's the first thing I want you to understand. Okay, as far as discussion of what we call the median nerve is concerned. Now, remember that whenever we talk about this pronator teres, then it tells us something. It is one of the superficial muscles, okay, as far as the anterior or the flexor compartment, okay, of the forearm is concerned. And so it tells me that there will be other superficial flexes of what we call, the forearm. And what are these superficial flexes? My friends, one thing that I want you to understand, yes, which is very important, and I will emphasize on a particular one. Yes, we look at the superficial flexes. We are talking about flexor carpi radialis. We are talking about the palmaris longus muscle. Okay, these are the things I'm talking about, but not. Please, I want you to become aware of that, but not flexor carpi ulnaris, because flexor carpi ulnaris, we'll be discussing it in another section. That one will rather be supplied by, of course, the ulnar nerve. So please understand this one. I'm talking about the median nerve. Yes, most of the musculature over there in the forearm, yes, we'll be getting that motor supply from, of course, the median nerve. But remember that as far as the superficial flexes of the forearm is concerned, we are talking about flexor carpi radialis, we are talking about palmaris longus, but not flexor carpi ulnaris. I want you to take that one out, including this, of course, pronator teres that I've just discussed to you. But my friends, importantly, the one I want you to put in mind, which will be useful in the clinical application, okay, of injuries to this median nerve, is for you to understand flexor, flexor digitorum superficialis. Flexor digitorum superficialis. I want you to know about that one. It's also one of the superficial muscles, although some authors will put it under intermediate group of muscles. I want you to highlight that one. flexor digitorum superficialis. So it means that this muscle is very important as far as causing flexion, okay, of the fingers at what we call the proximal interphalangeal joint. Proximal interphalangeal joint. Okay, so if I talk about proximal interphalangeal joint, this is what I mean. Okay, if you look at my fingers, okay, this is what we call the proximal interphalangeal. These are the proximal interphalangeal joint, and the musculature which is relevant in doing that is, my friends, is flexor digitorum superficialis. Now you look at this area, you also have what we call, the distal interphalangeal joint. So I'll be coming to that one too. Now, apart from these superficial muscles, okay, one thing too that I want you to understand is that this median nerve gives off a branch, okay, and this time around that branch, okay, runs in front, just in front of what we call the interosseous membrane. We know that in the forearm we have the radius and we have the ulna. There will be a membrane over there which is of course the interosseous membrane. Now remember that when we discussed the radial nerve, we said that the radial nerve gave a branch, okay, which of course after piercing what we call the supinator muscle, we call it the posterior interosseous membrane because it ran behind the interosseous membrane. This time around it is running anterior in front, okay, so it becomes a deep muscle over there, a deep branch of this median nerve, okay, and so that's what we are calling it, what, anterior interosseous nerve. So a branch of this median nerve, which this time around it will be giving supply, motor supply to the deep muscles of what we call the forearm, okay, anterior compartment of forearm. That is what we are calling what we call the anterior interosseous nerve. So please understand that whenever you hear posterior interosseous nerve, think of a branch of the radial nerve. When you think of anterior interosseous nerve, think of a branch, a deep branch for that matter, of what we call the median nerve. And for this reason, because it's the deep branch, then it's going to give motor supply to the deep muscles of the flexor compartment of what we call the forearm. And what are these deep muscles? I want you to understand these ones very importantly. Number one is what we call flexor digitorum profundus. Remember I told you about flexor digitorum superficialis, which upon its innervation, it will cause so upon contraction it will cause flexion at the proximal interphalangeal joint. And so causing flexion at the distal interphalangeal joint is what we call flexor digitorum profundus. Now the word profundus has to do with deep. Okay, so that's one thing that we find. But the important thing I want you to become aware of that is that the flexor digitorum profundus is a hybrid muscle. It's a hybrid muscle. Now, oftentimes in the classroom, I tell students that yes, there are some muscles we call them hybrid muscles because they have dual innervation. And one of such muscles is the flexor digitorum profundus. For the reason that, yes, its lateral half, and that's the one we are talking about today, okay, its lateral half, okay, where is the one who is towards where the thumb is, so lateral half is supplied by, of course, this median nerve we are talking about, the anterior interosseous branch of the median nerve. Because we know that the medial half will be taken care of by the other nerve, which will be come to it later on. Okay, so please understand this, that of course we are talking about the lateral half, one half of what we call the flexor digitorum profundus. So that upon contraction, it will cause what we call the distal interphalangeal joints, okay, of these two, what do you call it, fingers, or these two digates, okay, to flex. Okay, so that's what we mean, flexion at the distal interphalangeal joints. So that's what we are talking about. Okay, that's the first one, where it's supplied by, of course, the anterior interosseous, nerve. Now, number two is the one which will be going on the thumb. Okay, so we call it flexor pollicis longus. Flexor pollicis longus. Now, this time around, we are not talking about, proximal or distal interphalangeal joint of the thumb. The thumb has just one interphalangeal joint. Yes, there are two phalanges over there. And so we talk about interphalangeal joint of the thumb. So for this reason, the other muscle, where is a deep muscle as far as the anterior compartment of forearm is concerned, where is getting that motor supply from anterior interosseous nerve, where the deep branch of the median nerve, okay, is who? Is of course the flexor pollicis longus. And my friends, no doubt about that, that the deepest muscle as far as the anterior compartment of the forearm is concerned is that quadrangular shaped muscle that we find over here, okay, the one we call it, of course, pronator quadratus muscle. Not really to talk about that and so much, but as far as the deep muscles are concerned, please understand that you need to understand, the flexor digitorum profundus that is giving motor supply to the lateral half, okay, of what we call the flexor pollicis, flexor digitorum profundus. And that is also giving motor supply to flexor pollicis longus. And as far as the median nerve, okay, is concerned, the initial supply is concerned, before giving this deep branch is concerned, it will be given superficial branch, a branch to, of course, flexor digitorum superficialis. Note these three muscles that I just mentioned, so that we can look at the differential diagnosis. Okay. Now, apart from that, okay, then what will happen is that, yes, after dealing with the deep one, yes, the median nerve will continue, okay, by running deep. Now, over here at this area of the carpus, there's a rest region, so we call it carpus. There's a retinaculum, which we call, because there's a flexor compartment of the forearm, we call it flexor retinaculum. Okay, so that band, okay, over here, which of course will keep some content in here, that's the flexor retinaculum. And my friends, one of the contents to be kept over there, which will be running deep to the flexor retinaculum, is of course this continuation of the median nerve, which I can say is the superficial branch of this median nerve that I'm talking about. Okay, so over here, it will be running deep to it. Okay, now when it runs deep to it, it goes and of course it gives supply to this region. Okay, now this area is the thinner region of the palm. Thinner region of the palm. Now remember that the thinner region of the palm, yes, largely the motor supply will be coming, okay, from what we call this, median nerve. Okay, so usually we call it that branch that after running deep to the flexor retinaculum, median nerve running deep to the flexor retinaculum, the supply that is going to give to this area of thinner area, this thinner area is something we call the recurrent branch of the median nerve, of the superficial branch of the median nerve. You can say that. Okay, so that is what we see. But I want you to understand something over here. The musculature which are contributing largely to the thinner eminence. Remember that we have thinner group of muscles and we have muscles that produce the thinner eminence. Now that's something which confuses people a bit, but I want to clarify it over here. Now, as far as the thinner muscles are concerned, one thing I want you to understand is that we have what we call flexor, abductor pollicis brevis. Abductor pollicis brevis, we have flexor pollicis brevis, we have opponens pollicis, okay, and then we also have flexor, palmaris brevis, and of course we also have adductor pollicis muscle. My friends, as far as the musculature which are going to produce this thinner eminence is concerned, adductor pollicis is not contributing. Now remember that when we treat all the nerve, you understand that the adductor pollicis, where it's over here, okay, one of the thinner muscles will be getting is the last muscle to be supplied, but of course the ulnar nerve. So oftentimes we call it the graveyard of the ulnar nerve. Okay, that is it's not part of the muscles which are going to be supplied by, of course, this recurrent branch of the median nerve. Okay, the nerve that is supplying the muscles that are producing the thinner eminence. Now, what are these muscles? So let me just tell you. Palmaris brevis is not, and I want you to become aware of that. Palmaris brevis, although it's that guy over here, it doesn't contribute much to the eminence. It's not supplied by, of course, the median nerve. It's rather supplied by the ulnar nerve. We will see that one later. But I want you to understand this. The musculature, as far as the thinner eminence is concerned, supplied by, of course, the median nerve, is, of course, number one, flexor pollicis brevis, and number two, abductor pollicis brevis. I don't need you to worry about these ones, but as far as the clinical application is concerned, the third one is the most important one I want you to become aware of, because that's the one which often will produce the clinical manifestation of the injury. My friends, it's something we call opponens pollicis. Opponens pollicis. And let me tell you something about opponens pollicis. Opponens pollicis is very relevant as far as, causing opposition movement of the thumb. Okay, so for you to do this, okay, opposition movement of the thumb, okay, it's done by, of course, opponens pollicis. And so failure to do that opposition movement, and for that matter, injury to the opponens pollicis, will lead to something we call ape-thumb deformity. So someone comes to you and that's how the position of the thumb is. Okay, so it means that this person cannot medial rotate the thumb to oppose the other fingers. Okay, that is something we call ape-thumb deformity. So one thing I want you to become aware is that whenever there's an injury, okay, to this, of course, median nerve, okay, and it affects that area, whichever area that is affected, except in the case of isolated injury to the anterior interosseous nerve, whether it's a high injury or a lower level injury, the presentation will be the same. You will see what we call, ape-thumb deformity. Ape-thumb deformity. Now, so let's move on. Okay, so that's one thing I want you to become aware of. Now, it's not only that one, because we even have the lateral true lumbricals, okay, something I've done already, the unipinnate lumbricals, the L1, L2 lumbricals, okay, the worm-like, musculature over there, as far as the intrinsic muscles of the thumb, of the hand is concerned. We'll also be getting that kind of motor supply from, of course, this median nerve that we are talking about after running below what we call flexor retinaculum. Okay, so this area, okay, there's a carpal tunnel over there. So if there's a compression, okay, of this flexor retinaculum and there's that carpal tunnel injury, then you know which musculature is going to be affected. Yes, I told you about the thinner eminence that there will be, if that happens, then of course that kind of ape-thumb deformity will be seen. The ape-thumb deformity, you see that the musculature over here is supposed to produce the thinner eminence will be wasting. Okay, so the place will become so thin. Okay, then it tells you that the musculature, their nerve supply is not coming, and that's why they are wasting over there. So I want you to understand these applications over here. Now, one other thing, which is of course the most important thing which I'm going to tell you, is there will be another branch, and that one is cutaneous in nature. It's not giving motor supply, it's giving that branch digital branches to, of course, so the fingers over here. So look at the fingers over here, okay, together with the nail base, okay, lateral 3.5 of the fingers, okay, the palmar aspect of the fingers, including the nail base, will also be supplied. But of course, the digital branch of the median nerve after running below, and I want to emphasize this, after running below the flexor retinaculum. And for that reason, whenever there's a carpal tunnel syndrome, there will be loss of cutaneous supply to, of course, the palmar aspect of the lateral 3.5 aspect of the digit, including the nail base. But my friends, in your reading, perhaps you might have seen that, yes, the median nerve doesn't only give digital branches to this area to give cutaneous supply to the digit, but my friends, also, it will give some kind of cutaneous supply to, of course, the lateral 3.5 aspect of the palmar aspect, okay, of the hand itself. I'm not talking about the digit, of the palm, okay, ventral aspect over here. That's what we see, not the digit. But that one, okay, the branch, okay, doesn't come after the nerve has run, under what we call the flexor retinaculum. No. Rather, that branch, okay, comes off, okay, from the superficial branch. As it goes over there, it comes off, okay, and it goes all the way to, of course, supply. So it runs superficial to the flexor retinaculum. It doesn't run deep to the flexor retinaculum. So it means that whenever there's a carpal tunnel syndrome, okay, one thing that you will see for sure is that there will be loss of cutaneous sensation to the palmar aspect of the digit, including the nail base or lateral 3.5 aspect of the digit, but it will exclude the palmar. The patient will feel the sensation in the palm. Why? Because the palmar, cutaneous branch of the median nerve doesn't run, okay, or doesn't come, okay, from a branch after it has run below the flexor retinaculum. Okay, so that is one thing I want you to become aware of. So my friends, we look at the application. What are we talking about? There could be injuries to this median nerve. First injury, which we are calling a higher injury. Now the high injury, it can happen, yes, in the axilla, it can happen in the arm, no problem. And it can also happen, okay, in, of course, a lower region as far as the elbow is concerned. Whichever area is a higher injury, and the clinical presentation will be the same. Yes, it will be the same. Now, so for this reason, there could be some kind of injury, something like, because I told you that the median nerve is the medialmost content as far as the cubital fossa is concerned. Then what happens is that if there's something we call, let's say, medial, supracondylar fracture, for instance, okay, then there could be that kind of injury to this, of course, median nerve. Yes, also something I've discussed already. We talk about this true-test ligament where individuals who present, okay, with the third head of what we call the, the coracobrachialis muscle, okay, there will be that kind of supracondylar spur. So there could be that kind of compression of this median nerve over there. Okay, that one too can happen. Okay, and therefore there will be that kind of injury to the median nerve. Now, whatever the case may be, whether it's a higher in the axilla, in the arm region, or in the elbow region, that is a higher injury to the median nerve. And so for this higher injury to the median nerve, what is going to be the clinical presentation? The clinical presentation will be like, yeah, first of all, there will be an ape-thumb deformity. Ape-thumb deformity. And the ape-thumb deformity, yes, what do we see? We'll be seeing that, yes, this area which we're calling the thinner eminence will become so small. Okay, will waste. The next one, because it's a higher injury, then of course, there will be loss of cutaneous sensation to, of course, the lateral 3.5 aspect of not only the digits, including the nail base, and also the palmar aspect too. Okay, that's what we'll be seeing. And as I told you, the one muscle which is, of course, very important as far as talking about the superficial muscles of the anterior compartment of the forearm, okay, flexor digitorum superficialis, I told you that one will be relevant in causing flexion at the proximal interphalangeal, at the proximal interphalangeal joint. So these are the areas I'm talking about. And so for this reason, the patient cannot, cause that kind of flexion at the proximal interphalangeal joint. Neither will the patient be able to cause flexion at the interphalangeal joint. Okay, so please understand this. This is where we are coming from. Okay, so that is the first presentation I want you to understand. A higher injury. So higher injury, you will see that. And so you ask the patient that the patient should, of course, flex. Okay, cause flexion. Now, please understand this. Whether it's a higher injury or it's a carpal tunnel syndrome, one thing is that the ape-time deformity will be observed. The only thing is that if it's a carpal tunnel syndrome, the injury is at a lower level. The only thing is that, yes, of course, what we'll be seeing is that the palmar sensation will be felt, but the digital aspect, including the nail base, will be lost. And that's how we can quickly, just by way of a quick differential diagnosis, to tell us that it's a lower injury that is in the case of carpal tunnel syndrome, or it's a higher injury. Because in the case of a higher injury, both cutaneous sensations will be lost. But if it's a lower injury, then one thing that we'll be seeing is that the palmar sensation will not be lost, but rather the digital, sensation will be lost to lateral 3.5 aspect of the digits, including the nail base. Okay, so please understand this one. But one other thing too I want you to understand, which you can also use, is that, yes, we said that as far as the superficial branches, is concerned, flexor digitoris superficialis, helping you to, of course, perform, flexion at the proximal interphalangeal joint is concerned. Yes, we said it's not be lost, it will be lost, together with, of course, the distal interphalangeal joint. But remember, there was a catch that as far as the flexor digitorum profundus is concerned, the motor supply to, rather this time around, to, of course, the lateral half of the fibers is by the median nerve, the deep branch of the median nerve, anterior interosseous nerve. And so it tells me that not every part. And so you ask the patient will come with the ape-time, and then you can also ask, after doing the cutaneous sensation, you want to still do further clarification, you ask the patient to flex, so to flex the, interphalangeal joints, the fingers. The patient will not be able to do it, and usually these two will still be hanging this way. And oftentimes, sometimes even this one may be spared, but this one, the index finger, will still be pointing. Why? Because, of course, it's so lateral to this point that both the proximal and interphalangeal joints, yes, will not be able to flex. And this is something clinically, we call it pointing index finger. So whenever the patient comes to you with an ape-time, you want to tell whether the injury is from a higher level or is from a lower level. And lower level, I mean carpal tunnel syndrome. You ask the patient to flex, the digit. And most likely, if it's a higher injury, what we'll be seeing is that we'll be seeing this one, that there will be a pointing index finger at you. So that's what we call pointing index finger in case of higher injury to, of course, the median nerve. Apart from the fact that there will be loss of cutaneous sensation to both the palmar aspect together with, of course, the digital aspect, including the nail base of the lateral 3.5 aspect of the fingers. Yes. Now, so having seen that, and I also told you, we've discussed this one already, the carpal tunnel syndrome, that's the lower injury. That the lower injury, what are we going to see? Already, the patient will come with the ape-time. But what do you see? If you ask the patient will be able to flex all the digits at both the proximal and distal interphalangeal joint. Why? Because already, of course, flexor digitoris superficialis would have been supplied. Also, the deep branch by of anterior interosseous nerve would have been given supply to, of course, this, flexor digitorum profundus, lateral half. And so there will not be any problem with the flexion. Then clearly you know that this, of course, the case of carpal tunnel syndrome. But as I told you, the differential, the next thing that you can also do is to test for cutaneous sensation. That for cutaneous sensation, the palmar aspect over here will be felt. But at the digits, there will be loss of cutaneous sensation to the lateral 3.5 aspect of the digits, including the nail base. Now, there could also be an isolated case where, of course, the anterior interosseous nerve could be injured. Yes, there could be a case like that. And so in such a case, one thing that we'll be doing, now remember that I told you that anterior interosseous nerve, apart from giving, of course, apart from supplying flexor, giving, motor supply to supply the lateral 1/2 of what we call the flexor digitorum profundus, together with, of course, the parietal quadratus. I also told you about something that we giving supply So of course, the long, muscle where it's causing flexion are the thumb, flexor pollicis longus. Okay, and so for this reason, if you want to test that it's indeed, okay, it's not a high injury, neither is it a carpal tunnel syndrome, but rather, it's rather an injury, okay, to, of course, the anterior interosseous nerve, an isolated case injury, which you can also call a deep injury. Okay, then what will happen is that you ask the patient, remember that flexion, okay, at what we call the distal interphalangeal joint is by the, of course, the deep branch of what we call the anterior, of the, median nerve, the anterior interosseous nerve. And so we ask the patient to flex, and then the flexor pollicis longus. Okay, so for you to test clinically that the anterior interosseous nerve is not injured or is injured, you have the patient to flex, okay, at the distal interphalangeal joint of the index finger, distal interphalangeal joint of the index finger, and then the interphalangeal joint of what we call the, thumb. Okay, so you ask the patient to do this. Okay, so now, once I've been able to do this so that I can get this area to be roughly circular, okay, this area between the thumb and index finger to be roughly circular, because I have been able to flex my interphalangeal joint of the thumb, okay, and I've also been able to flex my distal interphalangeal joint of the index finger. It tells me that the anterior interosseous nerve is injured. Okay, now if the patient's anterior interosseous nerve is injured, then this musculature will be weak and therefore they cannot flex. And so what will happen is that you ask the patient to flex, and this is what the patient will produce. And this is something we call collapsed OK. Collapsed OK sign. So this is the correct OK sign. And this is, of course, the collapsed OK sign. Okay, so these are the things that, of course, clinically we can use to do the differential diagnosis of course, the median nerve. My friends, I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.